Welcome to yet another interesting RRR series presented by StudyMEDIC to intensive preparation for your MRCOG Part 1 examination. And this is Dr. Priyadarshini Lingaraj today with you. And the module we have taken for today's discussion is microbiology. And in this, today we are going to focus on some very, very important perinatal infections, including Rubella, Parvovirus, chickenpox, and herpes. So what's so special about these infections? Well, firstly, they're very, very commonly asked in exam. Second thing, all of them have quite a significant clinical relevance, and most of them have some GTGs also related to that. So that means these topics are considered very, very important when you're preparing for your exams. So let's go and see what kind of questions we can expect in exams pertaining to these infections, and also what does the GTG say about this. So to start off with these infections in pregnancies, when we have a viral infection, first of all, we have to know how do we differentiate the different types of infections. Start off with, if an infection has got some pruritus also, then we need to think whether there's an underlying exacerbation of a skin condition like eczema or dermatitis, or is it very, very specifically related to pregnancy, like cholestasis of pregnancy or polymorphous eruption of pregnancy. If there's no pruritus but just the infection, then we have to look at the rash, whether there is a maculopapular rash. If there is a presence of a maculopapular rash, then we have to think of viral exanthems like Rubella, Parvovirus, measles, etc. Or it can be related to meningococcus, streptococcus, syphilis, CMV, etc. If it's not associated with a maculopapular rash, but if there's a vesicular rash, then we need to think in terms of herpes infections or varicella. Well, if the diagnosis is not fitting into anything, then we'll have to refer the patients to dermatology and to look at other causes of this. When we talk about these infections, most of the viral infections are spread by hematogenous route. The most common ones are Rubella, Cytomegalovirus, hepatitis, erythemas, and varicellas. It can also be spread by other routes too. But what are the other infections which can mimic? Well, they are Toxoplasmosis, Listeriosis, syphilis, etc. Not to forget all viral, the bacterial infections like the group A streptococcus and the group B streptococcus also need to be kept in mind when we're dealing with infections in pregnancy. The transmission, most of the infections in pregnancy can be spread either by the transplacental transmission, whenever there is a disruption in the placenta or there is a fetal-maternal hemorrhage, it can lead to a source of infection. It can traverse the fetal membranes, or it can be an ascending infection right down from the vagina, the most common one being GPS. In the mother, the impacts of these infections can lead to sepsis, respiratory distress, obstetric hemorrhage, and in very serious conditions, it can even cause maternal death. In the placenta, when these infections enter the placenta, the oxygen carrying capacity and the nutrient carrying capacity of the placenta gets reduced, and also placenta acts as a very good reservoir for reinfections. So the chances of repeated infections are very, very common, and this in turn can lead to labors also. Coming to the fetal impact, any kind of infection can lead to growth-restricted babies. So we need to think of infections when we are dealing with a growth-restricted or an IOGR baby. It can also lead to birth defects like blindness or deafness. Neural development can be affected, can lead to microcephaly, and there can even be bone marrow depletion. Well, the impact depends on the type of organism and also the trimester at which the organism is getting transmitted, and also what are the immune factors in the mother. We have some images. Main reason behind these images are sometimes along with the scenario, there can also be an image which can be tested in the exam. The first image, we have multiple small vesicular rashes, which is most commonly seen with varicella. In the second one, we have a newborn baby. When we closely observe the eyes have cataract. This is very, very specific of Rubella. The third baby down below, we have a baby whose head is quite large, compared to the body. That is hydrocephalus. As we know, hydrocephalus can be associated with cytomegalovirus. Not to forget, even toxoplasmosis can have a hydrocephalus baby. Last few images are ultrasound images, and these images are all pointing towards the fetal brain. And when we look, there is calcifications and there is periventricular, little bit of hemorrhage and dilatation. And this is very, very suggestive of cytomegalovirus infections or CMV infection. When we have a scenario-based question, like as we have now, we have a woman who's previously had a genital herpes. She is presenting with a preterm pre-labor rupture of membranes at 32 weeks of gestation. Clinical examination reveals that she has typical lesions of recurrent genital herpes, and the assessment of the fetal and the maternal well-being are otherwise normal. So what is going to be the management plan like? So first, we need to understand that it is a case of recurrent genital herpes. And secondly, we have to know that she is presented way before, that is, she is at 32 weeks of gestation. So the options we have here are we going to start her on oral acyclovir or IV acyclovir? What is the role of steroids? Are we going to use them or are we going to avoid them? Lastly, we have to think about the delivery. Are we going to expedite the cesarean section or are we going to offer her an expectant management? Let's see what the guidelines have to say and then we will come back to discussion. Now, how do we deal with a case of herpes in pregnancy? The first thing we have to see is whether it is a case of primary genital herpes or recurrent genital herpes. If there is primary genital herpes in the first and the second trimester, then the primary episode has to be treated with standard dose of acyclovir. Whenever there is primary herpes in the third trimester, then we are going to treat the primary episode with the standard doses of acyclovir. However, for cases of recurrent genital herpes, we are going to treat the episodes only if necessary with a standard dose of acyclovir, and we are going to consider the use of acyclovir 400 mg TDS from 36 weeks of gestation. If the primary herpes has occurred in the third trimester, we are going to consider using acyclovir 400 mg TID till delivery. And you have to recommend a planned cesarean section, especially if this episode is within the last 6 weeks of delivery. Now, coming to the mode of delivery, we have to see if it's going to be a vaginal delivery or a cesarean section. For cases of recurrent genital herpes, we can offer the woman a vaginal delivery. For cases of primary genital herpes in the first and second trimester, again, vaginal delivery is not contraindications and it can be offered. However, if there is a primary herpes which the woman develops in the third trimester, then we have to consider offering her a planned cesarean section. And if the vaginal delivery is opted by the mother or there is a vaginal delivery that is in place, you have to inform the neonatologist about this and the baby's conditions has to be evaluated. If the baby is well, despite being well, we need to start the baby on acyclovir IV 200 mg per kg TID for 10 days when we await the results. However, following a vaginal delivery, if we see that the baby is unwell, then we need to perform a lumbar puncture to rule out HSV PCR. In case cesarean section has taken place, we need to inform the neonatologist and offer the baby a normal postnatal care, and the baby has to be discharged home at 24 hours if it's well. And of course, we need to advise the women later on there can be some concerns and they'll have to come back if there's any. What do we do if the woman has been undergoing a normal vaginal delivery following a recurrent herpes or there's a primary herpes in the first and second trimester? We have to offer the baby normal postnatal care. However, if the woman has had any HSV lesions at the time of delivery, then we have to observe the baby for 24 hours. And if the baby is well, we can discharge the baby. However, if there is any concern, they will have to return back. Now, going back to the scenario that we were faced with here is, first thing, she's at 32 weeks. And second thing, it's a case of recurrent genital herpes. Okay. So we saw IV acyclovir is not used and it's only oral acyclovir. Along with oral acyclovir, Are we going to use steroids? Yes, it is needed because the weeks of gestation is only 32 weeks. And are we going to expedite with cesarean section? No, it is not required. We can offer her an expectant management so that we can take her as close to term as possible. So the answer is going to be option B. Because it is before 34 weeks, we are going to give her starter on oral acyclovir and we are going to give her steroids also. Coming to another question, we have a woman who is 26 weeks pregnant and she's referred by the general practitioner because of a recent contact with a friend who has had chickenpox. On testing, she's not immune to the infection. What are we going to do for her? So coming to chickenpox, again, we have a very, very beautiful guideline which is going to explain about the management of Varicella Zoster. Now, whenever there's a history of contact with Varicella Zoster, first thing is to see the significance of the contact. We need to clarify it. If we consider it to be a significant contact, the first thing that has to be tested is whether the woman is already immune to varicella. If there's a past history of chickenpox, nothing is needed. Only have to reassure her and return her to the normal antenatal care. However, if she's not sure of whether having a past history of chickenpox, then we have to check her blood to look for varicella zoster virus IgG. If IgG is present, means nothing else is needed in addition and she can back to her routine care. However, if IgG is not present, then we have to start about treatment. What to do if the woman has had a contact and already developed chickenpox? Means the woman is already infected. Now, what are we going to do? The first thing, if the woman has got a contact and is not immune to varicella zoster, the first thing is to give her varicella immunoglobulin, which is less than 10 days since the contact. We have to advise the woman that she is potentially infectious from 8 to 28 days after contact, and we'll have to discuss about the postpartum varicella immunization. Now, what if the woman is going to, despite all this treatment, she's going to develop the chickenpox? Then we have to avoid contact with potentially susceptible individuals, especially other pregnant women and newborns. Second thing, we are going to start symptomatic treatment and hygiene needs to be advised. Now, if the woman is presenting within 24 hours of the appearance of the rash and also her weeks of gestation is more than or equal to 20 weeks, then we can give her acyclovir. However, if the woman is less than 24 hours and her weeks of gestation is less than 20 weeks, still acyclovir can be considered. And you're going to avoid the delivery of the baby at least 7 days since the rash has appeared so that there is enough amount of immunity and the immunoglobulins are being passed on to the neonate. Now, if the woman has received varicella immunoglobulin and she has developed severe infection and the woman is at a high risk of any complicated chickenpox, means she is under the category of severe infection. This is the time where we are going to give her intravenous acyclovir. And another important week of gestation to remember here is if this infection is less than 28 weeks, then we'll have to tell her that the possibility of developing an infection, a congenital infection, is almost 1%. So we'll have to rule out fetal varicella syndrome in them. So the woman has to be referred to a fetal medicine specialist at 16 to 20 weeks or 5 weeks after the infection. So this has to be kept in mind. And what are they going to do? They are going to perform an amniocentesis to detect the varicella DNA, and it may be considered and it may be offered to these women. So in the scenario that we had here, is a woman who's only 26 weeks pregnant and she's only got a contact and she's not immune also. Are we going to admit her for an isolation area? Admission is usually not required. Are we going to inform the healthcare worker in the antenatal clinic of a potential exposure? Well, information needs to be provided. But however, in the immediate plan of care, are we going to offer her immunoglobulin vaccination or is it going to be a single dose of immunoglobulin or 2-dose course of immunoglobulin? These three are the most prompt ones. So for immunoglobulin, we have to remember it is just a single dose of Varicella Zoster immunoglobulin and a second dose is not required. Going on to another scenario, we have a pregnant woman presented with flu-like symptoms and backache, baby as delivered, respiratory depression, jaundice, and hepatosplenomegaly. What do you think is the most common likely, or what is the most likely cause of organism in this particular presentation? If we look at this presentation, we see there are only flu-like symptoms and there is no history of rash that the woman has developed. And looking at the features of the baby, there is respiratory depression, jaundice, and hepatosplenomegaly. So when we look at any viral infections which can fit into this criteria, it can be most commonly associated with cytomegalovirus infection. If the viral infection has been ruled out, then the second common cause can be toxoplasmosis. So coming to cytomegalovirus infection, we see 30% of the pregnant women without any antibodies. And 1% of the primary infection can occur during pregnancy, which can lead to 40% of fetal infections. Of the fetal infections, 20% can be symptomatic and 80% are asymptomatic. Whether they're symptomatic or asymptomatic, are the babies going to develop sequelae? Symptomatic babies, 90% of them go on to develop sequelae, whereas asymptomatic babies, the 10% can have sequelae. These sequelae can include various deformities, the various problems like mental retardation, hearing difficulties, and motor retardation. Of the 70% of women with CMV antibodies, we can see the fetal infection rate is very low, almost 0.2 to 2%. This can happen because of reactivation. And out of these, symptomatic infections are present in 0.5 to 1%. So on an overall average, what we have to remember, if the woman is going to develop CMV infection and it is symptomatic, then 90% of the babies can develop sequelae. And the most common methodology to determine whether the baby is being affected or no is to see the ultrasound. And in the ultrasound, the most common features that we see are there can be hydrocephalus, there can be microcephaly also, there can be periventricular calcification and ventricular leukomalacia. So if there is a congenital CMV infection, what are we to do? First thing, we have to confirm if there's a fetal infection by doing an amniocentesis, and this is usually done 6 to 8 weeks following the maternal infection or reactivation, and especially if the weeks of gestation is more than 20. We need to do a detailed targeted ultrasound every 2 to 4 weeks and a fetal brain MRI at 28 to 32 weeks. Sometimes this can even be repeated 4 weeks later. If this fetus is asymptomatic, then we can offer expectant management until delivery. After delivery, have to subject the fetus to a clinical, audiological, ophthalmological, and a lab and imaging assessment. And a placental examination is also required. However, if the baby or the fetus is mild or moderately symptomatic, then we need to consider in utero treatment. And if baby is severely symptomatic, again, we can offer expectant management or the option of termination of the pregnancy can be given to these couple. So even after termination of the pregnancy, we need to offer them postmortem examination and placental examination to the couple. Coming to some questions which can be as straightforward as this, which is the most common in utero infection causing fetal anemia in utero? So whenever a question is being targeted on fetal anemia, we need to remember we're talking about parvovirus. So Parvovirus B19, whenever we have a woman who has got a recent exposure to parvovirus or has a symptom, we need to test for parvovirus, IgG and IgM. If the IgG is positive and no IgM, that means it is just a past infection and just reassurance is enough. However, IgG is negative and IgM is positive, then it means it is a possible recent infection. And this woman needs to be referred for an ultrasound and a middle cerebral artery systolic velocity Doppler. That is an MCA-PSV Doppler. Now, what is the importance of doing this MCA-PSV Doppler? This is the modality by which we are going to pick up fetal anemia. If the Doppler shows there is no high drops of fetal anemia, then she will be subjected to serial ultrasound every 1 to 2 weeks. And this should be repeated even up to 12 weeks post-infection. However, if there is any abnormalities in the Doppler or in an ultrasound, we see there is high drops that's being developed, then the woman is being referred to fetal medicine for consideration of fetal blood sampling and intrauterine transfusion, depending on the degree of anemia. So the cutoff that we take for MCA PSV is more than 1.5 moms. Coming back, if we are testing the women for IgG and IgM, and if both are negative, it means there is no infection that is present, let it be past or let it be present. So we have to request the patient for a repeat blood test in 3 weeks. And we have to see what the results are. Depending on the results, the management options are going to vary in these women. The other important thing to remember here are few percentages which can be tested in exams. So for congenital CMV infections, first trimester the transmission rate is 35, second trimester it's 40, and third trimester the transmission rate is 59%. However, we need to remember the earlier the infection, the more serious it's going to be. And the most common finding in CMV infection is what we see here. These are called as periventricular calcification. This is very, very pathognomic of a CMV infection, which can be seen in the ultrasound images. Going on next, few important points to remember about parvovirus. Parvovirus B19 is also called as fifth disease. The appearance of this is going to be the slapped cheek appearance, and the incubation period is going to be 5 to 7 days post-exposure. However, the infectious time is going to be 3 to 10 days post-exposure or the rash appearing. Vertical transmission, if women's weeks of gestation is less than 15 weeks, it is almost 15% transmission. 15 weeks to 20 weeks, the transmission increases to 25, and term it is 70%. Though the vertical transmission increases as the weeks of gestation increases, however, infectivity is very, very severe if the transmission happens less than 20 weeks. We see that the fetal loss is almost 90% when the infection is very early. How are we going to diagnose this? This is by taking the IgM. And high drops is seen in 3% of the babies after 5 weeks post-infection, and intrauterine fetal death diagnosed in less than 10% of the babies 4 to 6 weeks after post-infection. So this tells us the importance of following up these babies even post-infection after 5 to 6 weeks. Coming to rubella. Now, rubella, the typical appearance of the rash is usually behind the ears. Along with this, the women can have headache, coryza, and lymphadenopathy. Incubation period of rubella is somewhere around 2 to 3 weeks, and the woman is going to be infectious from 7 days till 7 days of onset of rash. Again, coming to vertical transmission, less than 12 weeks, the transmission is almost as high as 90%. But as the weeks of gestation prolongs, we see that the transmission is reducing. It reduces to 55%, and after 16 weeks, it's 45% only. However, whenever the transmission is less than 16 weeks, the congenital rubella is seen in 20% of these neonates. And how are we going to diagnose rubella? It is by the measurement of immunoglobulin. And this has to be taken at least 7 days after the rash. So IgG is suggestive of a past infection, and IgM is suggestive of a recent infection. Now, whenever a woman is tested positive for rubella and she's only less than 12 weeks gestation, termination of pregnancy has to be offered to her because of the very, very high rate of congenital rubella syndrome. With 12 to 6 weeks of gestation, the prenatal infections are quite high, and after 16 weeks, the risk is very, very less likely. And these women who are not immunized prior to rubella needs to be advised about immunization post-delivery. So, thank you once again, everyone, for this patient listening. Hope this helps in your MRCOG background preparation. And do follow our page for more updates and more RRR series. And wish you all the very best for your exams.